Hello, my name is Dr. Anthony Zaki. I'm a cardiac surgeon at the Cleveland Clinic. I'm honored to participate in the CTSNet instructional video competition. The title of my presentation is Direct Aortic Impella 5.5 in Post-Cardiotomy Shock. In this video, I aim to provide a concise overview of post-cardiotomy shock, outline the most commonly used and accessible mechanical circulatory support options, and offer a clear step-by-step guide to performing direct aortic Impella 5.5 insertion with confidence and ease. To frame our conversation, I'd like to begin with a case presentation. We recently operated on a 77-year-old man with ischemic cardiomyopathy and preserved myocardial viability. He underwent coronary artery bypass grafting, although his targets were small and heavily calcified. In addition, we performed a Cox-Maze 4 with left atrial appendage occlusion for atrial fibrillation, as well as extraction of a pacer lead with an associated large right atrial thrombus. While weaning from cardiopulmonary bypass, the patient became hypotensive and was found to have severe global LV dysfunction. The team returned to full cardiopulmonary bypass support. The heart was thoroughly de-aired and graft patency was confirmed. Echo revealed no new findings other than diffuse LV dysfunction, thought to be due to myocardial stunning. An attempt was made to place an intra-aortic balloon pump via the femoral artery, but this was unsuccessful due to severe peripheral arterial calcifications. The patient's hemodynamics were maintained on high-dose inotropes and vasopressors. Given his tenuous condition and limited peripheral access, the chest was left open to allow for rapid central ECMO cannulation if necessary. Post-cardiotomy shock is a condition that represents inadequate cardiac output following cardiac surgery, leading to both end organ hypoperfusion and congestion. The hemodynamic profiles can vary widely, making management complex and highly individualized. Despite advances in surgical technique and critical care, post-cardiotomy shock continues to carry a high mortality. As surgeons increasingly operate on older and higher-risk patients, this condition is becoming more common, making it essential for the modern cardiac surgeon to be equipped to recognize and manage effectively. There are several key management principles to consider in post-cardiotomy shock. The first is a thorough and thoughtful preoperative risk assessment and optimization. We often perform a right heart cath prior to surgery to guide decision-making. Patients who are volume overloaded may require additional diuresis if possible. Patients with pulmonary hypertension may benefit from pulmonary vasodilator therapy, just to name a few examples. In some cases, mechanical circulatory support may even need to be instituted prior to surgery to achieve optimal conditions. The second principle is timely recognition. Early, proactive intervention is generally preferred to a delayed reactive approach. Once shock is recognized, the next step is to pursue targeted interventions. Especially when shock is unanticipated or new onset ventricular dysfunction is observed, the surgeon must quickly assess reversible causes. Has the heart been adequately de-aired? Is there a persistent arrhythmia or electrolyte imbalance? Is there a problem with a valve repair or valve replacement or a bypass graft that needs revision? Finally, there is increasing emphasis on early mechanical circulatory support. This approach helps preserve end organ perfusion, unloads the injured ventricle to reduce myocardial oxygen demand, and minimizes the reliance on high-dose inotropes and pressors, which can be damaging at elevated levels. Ultimately, the goal is to provide a safe bridge to recovery or advanced therapies if needed. Common mechanical circulatory support familiar to most surgeons include the intra-aortic balloon pump, veno-arterial ECMO, and the Impella, each with distinct advantages and disadvantages. The intra-aortic balloon pump works through counterpulsation, reducing afterload during systole and enhancing coronary perfusion in diastole. The main disadvantage, however, is that it provides minimal augmentation of cardiac output, typically less than a liter per minute. For this reason, current guidelines recommend against the routine use of intra-aortic balloon pumps in cardiogenic shock. The second and perhaps most popular and familiar to surgeons is veno-arterial ECMO, which provides full cardiopulmonary support. It can be initiated rapidly either by converting existing cardiopulmonary bypass cannulas to ECMO or through the addition of peripheral cannulas with the addition of a reperfusion sheath as shown as in the image here. However, the main disadvantage of VA ECMO is the significant afterload it imposes on the heart, which worsens myocardial oxygen demand. Following cardiac surgery, patients cannulated centrally are often left open-chested, which leads to deconditioning, risk of infection, and other complications in the ICU. Peripheral VA ECMO carries the risk of limb ischemia. In contrast, the Impella 5.5's primary advantage is active LV unloading. It results in dramatic reduction in myocardial oxygen demand. It can be implanted via the axillary artery or directly into the ascending aorta, depending on the patient anatomy and surgeon preference. The main limitation is the lack of direct oxygenation or gas exchange. However, by unloading the LV and reducing left atrial pressures, it improves pulmonary edema and thereby indirectly improves gas exchange. To underscore the hemodynamic effects of VA ECMO, I've included this pressure volume loop. Initiation of VA ECMO leads to a rapid rise in mean arterial pressure, which helps preserve end organ perfusion. However, this benefit comes at the cost of a significant increase in LV afterload. The sick, injured LV is often unable to effectively eject against this elevated afterload. As a result, LV EDP and pulmonary capillary wedge pressure both rise. Most importantly, there's a rightward shift of the pressure volume loop and an increase in the pressure volume area, which correlates to a higher myocardial oxygen demand and reduced capacity for LV recovery. Clinically, this translates to LV distension and stasis, thrombus formation, aortic valve closure and the risk of root thrombus, pulmonary edema, and refractory ventricular arrhythmias. These findings have brought attention to the importance of active LV unloading during VA ECMO support. Here's a dramatic example of a patient with severe LV failure supported on VA ECMO. While VA ECMO maintained perfusion to the patient's organs, the LV was distended, essentially at a standstill due to the significant increase in afterload. As a result, diffuse LV thrombus developed, highlighting the risks associated with inadequate ventricular unloading during VA ECMO support. In contrast, the Impella 5.5 actively unloads the left ventricle. Hemodynamically, this results in improved forward flow from the LV and an increase in overall cardiac output. We see a reduction in LV EDP, which translates to less pulmonary edema, and a leftward shift of the pressure volume loop with reduction in the pressure volume area, which correlates to lower myocardial oxygen demand and consumption. A commonly cited barrier to Impella 5.5 insertion in post-cardiotomy shock is the perceived difficulty of axillary artery exposure after a high-risk and prolonged operation. Direct aortic Impella 5.5 insertion, first described by Anderson and colleagues in the Annals of Thoracic Surgery in 2021, addresses this by implanting the device directly through the distal ascending aorta and limiting the need for axillary access and fluoroscopy. This technique requires an ascending aortic length of at least 7 centimeters from the aortic valve to the innominate artery and a distal ascending aorta free of calcium or significant atheroma. Careful planning of the aortic cannulation site is critical to leave room for the graft placement if Impella support is anticipated. The graft is tunneled under the skin to the supraclavicular fossa, allowing for chest closure, and patients can be extubated and ambulate while the device remains in place, helping prevent post-op deconditioning and other complications. When support is no longer needed, the device is removed easily at bedside by extracting the device catheter and ligating the vascular graft. The chest does not need to be reopened, heparin is not required, and the graft gradually thromboses without clinical consequence. This figure is provided for your reference courtesy of the device manufacturer and demonstrates proper 5.5 catheter positioning as assessed by TAE. Ideally, the distance from the mid-inlet of the device to the aortic valve annulus should be approximately 5 centimeters. The device should be oriented away from the mitral subvalvular apparatus and directed towards the LV apex along the intraventricular septum. The outflow portion of the catheter should be in the ascending aorta above the aortic valve, which can be confirmed on color flow Doppler. When titrating the device to the appropriate performance level, It's important to monitor the position of the intraventricular septum, particularly in patients with biventricular failure. At higher performance levels, the septum may shift to the left and the right ventricle dilate, increasing the risk of a potential suck-down event and worsening RV failure. Let's return to our case. On post-op day 2, the ICU team was unable to make progress in weaning vasopressors and inotropic support due to persistently low cardiac output and ongoing end organ hypoperfusion. The chest remained open due to myocardial edema and the ongoing concern for the potential need for central ECMO given his tenuous clinical status. Right heart cath and echo data confirmed a predominantly left-sided ventricular failure with preserved RV function. Based on these findings, the team decided to proceed with a direct aortic Impella 5.5 insertion for LV support. The following is a techniques video from this case. This video describes the technique for direct aortic Impella 5.5 insertion following high-risk surgery. The simplified approach provides full LV unloading and a forward flow up to 5 liters per minute, helping support patients through the perioperative period. An indicator used to mark the spot on the distal ascending aorta at least 7 centimeters above the aortic valve. The site is palpated to ensure no calcium or atheroma. A side-biting C-shaped clamp is applied to partially occlude the distal ascending aorta along the greater curve at the base of the innominate artery. A 15 blade is used to carefully enter the aorta layer by layer. I prefer a 15 blade over an 11 blade to minimize the risk of backwalling the aorta on entry. Fine scissors are then used to extend the aortotomy, cranial and caudally, to match the size of the 10 millimeter vascular graft through which the Impella will be inserted. The 10 millimeter graft is brought onto the field and a slight bevel is applied. The black line is oriented posteriorly to help prevent twisting when the graft is tunneled through the skin. It's important to leave the graft longer than necessary, as it can always be trimmed later after tunneling. A 5-0 proline is used to suture the graft end to side to the aorta using a routine parachute technique. The technique is similar to a left-sided coronary proximal anastomosis. The graft is parachuted down into place and the remainder of the anastomosis is completed. I prefer to pass the needle from in to out along the aorta throughout the entire anastomosis to minimize the risk of dislodging atheroma or calcium into the aortic lumen. The suture line is tightened and tied into place. A padded Fogarty clamp is applied to the graft and the side biting clamp is removed. Hemostasis is confirmed and any repair stitches are placed if needed. While pinching the graft, the padded Fogarty clamp is repositioned to the base of the graft near the anastomosis. A small supraclavicular incision on the right side, approximately 2 centimeters, is made parallel to the clavicle. A tonsil is used to create a skin tunnel and to grasp the vascular graft. The black line is kept posterior to prevent twisting. The graft travels underneath the sternoclavicular joint and the manubrium. The graft is carefully de-aired and the 23 French peel-away sheath is secured using the graft locks. From this point, the procedure proceeds similar to a standard axillary Impella. Our preference is to use a K&P catheter, which is inserted through the sheath and it's backloaded with an 035 starter wire. Under echo guidance, the wire and the catheter are advanced across the aortic valve into the left ventricle. We then do a wire exchange for the 018 Impella wire that comes in the insertion kit. The KMP catheter is removed and the Impella is brought onto the field. Purging is confirmed once there is solution exiting the device outlet. The 018 wire is passed through the device and the clamp is reapplied at the base of the vascular graft. As we break the hemostatic steel of the peel-away sheath, it's important to keep the graft clamped or else there will be a lot of bleeding. The assistant pins the 018 wire and the surgeon advances the Impella device into place using echo guidance. Here we see the Impella crossing the aortic valve, oriented away from the mitral valve along the septum. We aim for the bend of the device to sit near the aortic valve. The wire is removed and the device can be started. The clamp is then applied to the white cable in the vascular graft. The fastening clamps are removed and the peel-away sheath is split. The vascular graft is trimmed to leave about 2 centimeters protruding from the skin and subcutaneous tissue. It's important to keep the graft clamped at this point to prevent bleeding. The blue suture hub is advanced over the cable into the graft and secured using heavy silk ties. I prefer to advance the portion of the graft back into the chest cavity to create redundancy and minimize the amount of graft exposed above the skin. The clamp is then removed and hemostasis is confirmed. The Impella is secured to the skin using silk sutures, and any final positioning is made with the assistance of the echocardiographer. The catheter lock is removed, and from this point on, any adjustments to device position must be made by pushing the blue button. Here we see the final position. The device is well seated and well positioned, approximately 5 centimeters into the LV cavity with the bend at the aortic valve. The chest was closed in a routine manner, and this patient was transferred back to the ICU. Our patient did very well with the Impella 5.5. The device was titrated to a performance level of 7 with a calculated flow of 4.5 to 5 liters per minute. There was an immediate improvement in his hemodynamics with less pulmonary edema, less inotropic and vasopressor needs. The Impella was ultimately removed 11 days later and he continues to do well and recover. In conclusion, cardiogenic shock after cardiac surgery requires thoughtful and timely action to prevent poor outcomes. Early MCS is critical to restore end organ function, but support must also be configured in a way that allows injured ventricles to rest and recover. The direct aortic Impella 5.5 insertion technique provides a rapid, reliable, and straightforward method to unload the LV, helping bridge patients to recovery or, when necessary, more durable long-term options. I hope this presentation provides a foundation for your understanding of temporary mechanical support in post-cardiotomy shock and the role of the direct aortic Impella insertion technique. Thank you for your time and attention.